So most of you know who I am. I'm Joshua Adams. I have been here at MUSC for almost 4 years and have started our complex endovascular aortic program. Did a hybrid residency and fellowship at University of Virginia. I will be starting an aortic center back in my home state of Virginia at Roanoke, Virginia, at the Carilion Clinic. I really appreciate the opportunity to share our experience here with fenestrated and branched B-EVAR for suprarenal and juxtarenal aortic aneurysms. These are my disclosures. And the objectives of this talk, first we're going to talk a little bit about the history of B-EVAR and physician-modified endografts, and then how we developed a customized approach here, and then look at our outcomes of our experience. And when you look at the history of fenestrated B-EVAR, you actually have to go back to 1996 on the earliest publication, which came out of Korea, that demonstrated a physician-modified fenestrated graft with no stenting, but just the fenestration or window placed over the renal artery. I think that the folks in Western Australia really took this process to the next level. This is their first device that was published. This was a canine model, and you can see that on explantation, how the fenestration, this was again a non-stented fenestration, but you can see how it lines up with the ostia of the target vessel. This same group then formed an alliance with Bill Cook and began using a fenestrated device that they designed together. And from 1998 to 2000, they treated 13 patients with juxtarenal or suprarenal AAAs. And this was the first step where we left the physician-modified world, and these were actually commercially produced endografts. The 33 out of 33 target arteries were preserved. They used bare alignment stents, and we'll look at some of those pictures. There were no conversion to open operation or graft-related complications. This was a relatively short follow-up, 3 to 24 months, and during that time, there was one renal artery occlusion. And if you look at this, these are the first published pictures that really start to look very similar to what we do today with fenestrated B-EVAR, where the initial device had struts across. You can see the large fenestration had struts across it, and the renal fenestrations were both stented with a bare balloon stent. And then you can see that the steps of the procedure, the appearance of the devices in place, and the completion arteriograms look very similar to what we see today. And the follow-up CTs again show pictures that are very similar to what we have today. We then moved into Dr. Greenberg's work here in the U.S. at Cleveland Clinic, and their first publication on fenestrated B-EVAR, again with customized commercially produced endografts. Their first 22 patients with juxtarenal AAA had 58 out of 58 target arteries preserved. There were again alignment stents placed in many of those target arteries, with a follow-up short term of only 6 months, but 2 early and 2 late secondary interventions, and a 30-day endoleak rate of 4.5%. So good results. And with this device, you again see a very similar device to what we're using today. This was really the evolution of the Zenith fenestrated device, with the posterior constraining wire and Prolene sutures that were used to reduce the diameter of the graft to allow manipulation during deployment. Now you do see that we didn't have reinforced fenestrations at that point, so that's one difference. But again, the large fenestration was in the same size criteria, or same size category as to what's commercially available today in the U.S., and did have bare struts across across it. But you had the combination of small fenestrations, large fenestrations, and scallops. I'd be remiss to not talk about the work that was done here at MUSC in regards to the fenestrated physician-modified endografts that Dr. Uflocker, Dr. Robison, and Dr. Schoenholtz were a part of. And in this process, they deployed the graft out of the front of the sheath and made their fenestrations, and then muzzle loaded it back into the original delivery sheath for deployment. Then we look at the Cleveland Clinic experience with the 24-month outcomes of the, actually this was the multi-center trial, so 5 sites in the U.S. were moving again away from the physician-modified and to a commercially produced device that was available at five sites. You had 24-month outcomes of this multi-center trial. 30 patients were enrolled. There were 77 visceral vessels that were accommodated by fenestrations. And again, very good results. No aneurysm-related deaths, aneurysm ruptures or conversions, no type 1 or type 3 endoleaks. There were some secondary interventions, mostly related to the renal arteries. And then I think when we talk about physician-modified endografts, we have to mention Ben Starnes' work in Washington, where his initial physician-modified publication looked at 47 consecutive patients, large number of fenestrations for 58 renal arteries, 16 SMA, and 3 celiac arteries, a longer follow-up period of time, a very high success rate, and freedom from aneurysm-related death was also very good. The endoleak rate was only slightly higher, and of the 6 complications that were listed, 3 of which were access-related, the other were procedure-related, mostly related to the renal arteries, which has definitely proven to be one of the more challenging parts of this anatomy for this procedure. Then in 2012, the FDA approved the Zenith fenestrated device, and we talked a little bit during the first session about how that rollout was clouded in a little bit of controversy, and the access to devices really has continued to be an issue. But this was the first commercially and still only commercially approved and FDA approved and commercially available fenestrated device here in the U.S. It's constrained by a significant number of rules which limit its applicability to patients. You can only use up to three fenestrations or scallops. Only 2 of any one kind can be used. And again, the large fenestration is not a reinforced fenestration and has struts going across the device. There's also limitations on how far from the proximal edge fenestrations can be located, which can make extension more proximally, and extending your proximal seal much more difficult. So when we look at the U.S. custom-made devices, there was a definite trend. These are the number of sites that had access to a commercially produced CMD device, with an increase in number of those sites, but still very limited, and the total number of cases significantly increased over the years as this technology and these repairs were much more accepted. So what we did here is we kind of developed a CMD mindset and took the approach of utilizing a combination of commercially produced fenestrations and with the addition of physician-modified fenestrations or branches to extend the indications for B-EVAR and increase the proximal seal, which we think is absolutely critical to the long-term durability and success of these procedures. For an emergent repair, what this initially started out as was a purchase of the blank Zenith fenestrated devices for each diameter proximal device and a combination of standard distal devices. For elective repairs, we tried to work within the U.S. rule to minimize the amount of back table modification without compromising the seal or graft design. So we took an approach of utilizing as much of the commercially produced fenestrations as we could, but rather than the addition of parallel grafts or shortening our proximal seal, we took the approach of adding physician-modified fenestrations to the device to complete our procedures. We felt that there were a significant number of advantages of the Zenith fenestrated platform over the standard TVAR or EVAR devices, which had been used in most physician-modified endograft programs, one of which is the ability to minimize that back table time. The posterior constraining wires were already in place, so you didn't have to take the additional hour to get that done, as Dr. Odrich described and published, or used individual chromic sutures that you would then pop with the balloon to constrain the graft. There were advantages in the configuration of the graft, which included rapid tapers from proximal diameter up as high as 36 down to the 24 millimeter graft where the distal device would plug in, and the ease of repacking into the original delivery sheath, as we learned, was much easier with this device. And so we took an approach of pulling the device out the back, leaving the peel away in place. And one of the other benefits was that we were able to actually also fix the large fens and remove those struts that were going across, which allowed us to stent the large fenestrations as well. So I'm going to show a couple cases, examples. This is a patient with a trilobed aneurysm, juxtarenal aneurysm, with a large accessory right renal coming off of the middle lobe. And this was actually our first case of modifying a Zenith fenestrated device. We designed a fenestrated plan that incorporated a small fenestration for the left renal, a scallop for the SMA, and then we attached a small branch coming off of this portion of the graft, which allowed us to continue to vascularize the accessory renal, but still allowed a lot more overlap with our distal device by using a branch rather than a fenestration lower down on the proximal device. And you can see this device being delivered as we move through the steps with the fenestrated. Now, at this point in our experience, we were still using brachial access. We really no longer use brachial access except in extremely difficult cases. We instead use the conformable sheaths almost uniformly from a groin access. But this is a sheath out the SMA, and the left renal, the branch, doesn't really project all that well, but it's down in this region. At this point, we're out our fenestration and scallop, and so we go ahead and deploy the top cap in balloon mold, and then our stent into the fenestrated. And then we came from the arm and connected the branch to the large accessory renal that you can see is perfusing really the majority of the kidney. Finished the distal portion of the graft, and this is our completion. I'll keep my fingers crossed that the video is played on our follow-up. We now have 2-year follow-up on this patient with a maintained preservation of flow to the right renal, the SMA, and the left renal. Her aneurysm sac decreased in size and no significant endoleak was seen. This is a coronal view of the same patient where you can see the curve of that vessel, which we used a Viabond to connect as our bridging stent. And here is the 3D reconstruction with excellent flow to that right kidney. So a second case, a large suprarenal AAA, when a patient who had an occlusion of the left common iliac, a chronic occlusion, and was status post a right to left fem-fem bypass. The reason I bring that up and show this case is that when you're doing a fenestrated repair, you need to have dual access, either coming from the arm or coming from both groins with fenestrations. And You can see the anatomy on this patient. It's a large aneurysm, and our plan was to, this is a 3D reconstruction. You can see the fem-fem bypass and the aneurysm extending above the left renal and up to the level of the right renal. We took a standard ZFEN and added with a scallop, and then added a large fenestration for the SMA and smaller physician-modified fenestrations for the renals in the funnel portion of the proximal device. Took a little work to get across the occlusion, which we suspected was going to be the case. We ultimately ended up having to use an outback to re-enter into the aorta, and then balloon angioplasty, and then brought our 16 French sheath, which our technique evolved from using multiple large Ansel sheaths to go out over the guide wire through the fenestration and into the target arteries, to using a single conformable sheath to both select the artery or the fenestration and the target artery, as well as deliver the stents. And so the advantage of only having to use a 16 French sheath worked very well. This is the sheath that we prefer to use now, which is the Oscor Adelante Magnum. It's available in a 16 French and an 18 French, but the critical thing is the large valve area that we use to puncture, and it's very hemostatic, unlike some of the other larger bore sheaths that we've used in the past. Just click through some of these, but you can see a wire in the SMA already at this point, and the conformable sheath selecting the left renal, then the right renal, and then we just work our way back with wires after we deploy. This is what the sheath looked like at the level of the groin, balloon mold, and we've all seen the standard steps in the fenestrated repair, so I'll just kind of click through those a little quicker. We were a little worried about the flow through that recanalized left iliac, so we actually used formal angioplasty balloons, non-compliant balloons, in a kissing fashion down through, and this was the completion at 6 months, and we have a widely patent iliac limb, as well as all the target arteries with exclusion of the aneurysm sac. Another issue that we quickly became aware of that we were going to have to come up with a solution was type 1A endo leaks following previous EVAR repairs. And there's been a number of publications on this subject, and I think that the consensus is that complex fenestrated repair can salvage some of these patients and avoid an open repair, especially in patients that wouldn't do well with an open repair. The most important single measurement is the distance from your lowest renal artery to the flow divider of the previous endograft. And our initial approach was a fenestrated cuff, which seemed to work pretty well and really allowed us to stay above the flow divider. But as became apparent to us in discussions with some other centers, relining the entire graft was a more conservative, better approach. And so we evolved to using the ZFEN platform to reline the entire graft. We started based, again, adopting this CMD approach, and the approach that those 10 centers had was an inverted limb that was commercially produced. So we realized that the distal device of the ZFEN had some advantages over the standard TFFB or bifurcated abdominal device, and so this is an example of a patient who had more than 50 millimeters. So we did our standard fenestrated repair device design, and then distally we transected the contralateral gate, and then inverted that, sewed a running locking suture line, and also anchored it on the lateral aspect to avoid any inverted gate movement after deployment. And this is a completion where you can see we've moved I don't know how well it projects, but we've basically moved the bifurcation from right here up to here in essence, and we were able to fix this type 1A endo leak. Now, depending on what device was previously put in, there can be a lot of cases where you don't have the whole 5 centimeters of distance between that renal, and so we had to come up with another solution. This is a patient who's had a previous EVAR with suprarenal fixation. Again, we designed a 4-vessel fenestrated proximal piece. We did put some additional, these arrows are showing some additional constraint because this was a device that had, the previous device had suprarenal fixation. We were a little bit worried about how well we were going to be able to manipulate the graft just with the standard 20% reduction from the factory provided constraining sutures. So we used the same process and just took in a few more struts on the lateral aspect of those first 2 stents. We shortened the device in 2 ways. In this case, we took, there are normally 2 seal stents on the distal ZFEN device, and we transected the proximal aspect, but left the trifold wires in place intact, and also resected the gate as you saw previously. We inverted that, and then we used those trifold wires to attach proline sutures to help constrain and anchor so that we had good proximal control of the device, but that we could release it in a trifold fashion. This is the distal end. This is the length, which you can see gets us down into a range of 30 to 32 millimeters, which allows you to really fix just about any of the existing EVAR devices. This is the picture of the SMA balloon stent going up, and you can see this is the problem that we're seeing with a number of these patients. This is a patient who had a standard EVAR with suprarenal fixation that resulted in a type 1A endo leak. The patient was taken back to the operating room where endo anchors were applied, and they still had a type 1A endo leak, and then the patient was referred for potential fenestrated repair to rescue. So I think we have to be thoughtful about our approach to treating these short necks as well. This is the device when it's still constrained. You can see where the gate actually is, the distal end. And there it is deployed above the flow divider, which are these 2 marks right here. One last quick case of just what has become our most common configuration of devices in a parallel fashion to what I think people are seeing in the CND programs as well, which is a commercially produced fenestration at the lowest boundary for the celiac artery, and then modifying and adding the SMA and renal fenestrations. This is an example of that. You can see the commercially produced fenestration for the celiac, the SMA, and what this gives you, depending on the device, it gives you either basically 30 or 40 millimeters above the celiac artery to get into healthy aorta and really maximize your proximal seal. That's the completion. So our outcomes of our current experience from April 2014 through August 2016, we treated 26 patients with this technique. 30-day mortality was 0 with a median follow-up of 4.3 months. The median length of stay was 2 days. 91 visceral arteries were targeted, and we had a 90 out of 91 success rate. We created a dissection that involved one renal artery that we were unsuccessful, but otherwise all of our targeted arteries were successfully catheterized. There were 41 commercially produced scalps or fenestrations with 50 modified fenestrations. Our cumulative branch patency at the time of putting this data together was 100%, but as Pat Kelly said in our last session, is that nothing in medicine is 0 or 100, and that's absolutely true. We've now found that we lost one right renal artery, which was very anterior, and I'm suspicious of those renal arteries that come off at the 10 o'clock to 11:30 clock face, as to just because of the angulation that artery has to take. We did have 4 patients who underwent secondary interventions, mostly including refinement of the renal arteries. Our technique has continued to evolve where we used cone beam CT selectively as well, which I think would allow us to treat those patients to see some of that distal angulation of the more rigid ICAS stent in the renal arteries and lessen our overall secondary intervention rate. And we did have an IMA embolization for a large type 2. So in summary, ZFEN platform, I think, is an effective technique to expand the application of the only commercially available fenestrated device, and it allows us to push more proximal and gain healthy aorta to gain proximal seal. And there are some significant advantages of using the ZFEN platform for physician-modified endografting for those emergent situations over that of standard abdominal and thoracic endografting.